Welcome to Basic Charting from Gary White's from our lab book, Basic Clinical Lab Competencies for Respiratory Care. This should help you with your final exam. This is from Chapter 11, Documentation and Assessment Goals. So what is a medical record and why do we chart? One thing I want you to remember about charting and about the medical record is if you don't chart it, whether it's a paper record or it's digital, it didn't happen. It is a legal document and it provides a written source of information regarding the patient's health, all of their conditions, and any treatments and what happened during those treatments. You need to make sure that you record the facts, that you're clear, and that you're concise. And entries should be in order. So progress notes should go in order. You should document either during your treatment or immediately after. If you let it wait too long, you won't remember what happened. The medical record contains admission records, physician's orders, progress notes, the history and physical examination, and any examinations done by any consulting physicians or providers. It also contains a graphic record with trend values, so you can see day to day whether or not your patient is getting better or worse. Laboratory reports for important information that can help you pin down what's going on with your patient, like ABGs, complete blood counts, and specimen reports. There are also imaging reports for MRI, chest x-rays, as well as CAT scans, and any surgery that the patient has will also be a surgeon's report and information about that surgery, anything that happened during it. And also ancillary services chart in the patient's medical record. We are considered an ancillary service, so services like respiratory care, as well as occupational therapy, physical therapy, speech therapy, all chart, and discharge planning. There should be a plan of care in place as well that you may chart on, as well as a discharge plan, so that we can see whether the patient is moving forward in getting better in their plan of care. I want to stress that the medical record is considered a legal document. You can be fined and or let go for falsifying anything in the record. It is legal and binding. You do not want to conceal an incident, falsify data, write about things that you didn't do, and otherwise lie on the chart or on purpose omit information. Write what happened in clear and concise terms, and write only what happened, not how you feel about what happened. Reimbursement is tied to our charting. So third-party payers like Medicare, Medicaid, and other insurance companies depend on our accurate charting in order for them to get paid accurately. Failing to document your breathing treatments and other activities that you do as a respiratory therapist will result in loss of reimbursement and can adversely impact the hospital. So you want to make sure you chart accurately and on time. When you chart on the medical record, your data entry, whether it's digital or by hand should include the date and time that what you did occurred, your assessment before, during, and after of what you of the patient, what you did, what technique you employed. So how did you do, like how did you do the SVN? What did you use to give the SVN? How long you were with the patient's response to the therapy, and anything that happened that was unusual. This could include coughing throughout the treatment, feeling faint, anything like that, or the patient refusing to do the treatment. All of that should be charted. Charting by exception is something that respiratory therapists don't usually do, but it is a method of charting that employs fill-in-the-blank forms where only data that change are documented. And generally, we chart what we do. We don't chart by exception. Let's talk a little bit about goal assessment and documentation. We should have SMART goals, goals that are clear, that are easy for you and the patient to achieve, that are timely, and that you can measure. Some of these include oxygenation goals, ventilation goals, bronchial hygiene, and hyperinflation goals. And these can be part of protocols for your department, for the respiratory therapy department, and for the hospital. They can vary, and so make sure you know how to document within a protocol. Measurable outcomes that the patient is expected to achieve following an intervention of the healthcare practitioner. So, like O2 to keep oxygen greater or equal to 90%. You document an oxygen saturation of 88% on room air. You place the patient on 2 liters nasal cannula, and you document at rest a oxygen saturation of 92%. All of that would relate to oxygenation goals. That goal in the patient orders is set. Ventilation goals can be similar, as can bronchodilator hygiene. Computer-aided documentation. We are in the age where because Medicare required it, most places, most hospitals and acute care facilities require that you have electronic charting. Some of the advantages, and one that I saw as a practitioner, is that it improves the quality of the care that we give the patients, as well as the accuracy, especially of orders. We had a 70% decrease in the rate of pharmacy errors when we went to orders that were electronic. People couldn't read the doctor's handwriting, and so when we switched to electronic orders, all of a sudden all the orders are typewritten with an electronic signature. We knew exactly who wrote the order and exactly what they wanted. It keeps information up to date. You can find up-to-the-minute documentation, and again, I stress that you should document as you go. So either documenting in the patient's room or immediately after giving a treatment or participating in a procedure. Electronic charting and screens allow us to do that. It promotes legibility. I don't have to count on not being able to read that handwriting. Improves the availability of information and conserves your time. Some documentation guidelines and abbreviations. Each hospital or acute care place will have a list of approved abbreviations. Make sure you only use abbreviations from the approved list. acceptable abbreviations and some abbreviations, things like QID meaning 4 times a day, TID meaning 3 times a day, Q2 PRN meaning every 2 hours as needed. Most of those are pretty standard charting documentation. So you want to be accurate and brief when you document. And so using approved abbreviations help with this. So I hope this has helped you. If you have any questions, please reach out to me via email and I'll get back to you as soon as possible, usually within a day. Thank you. Have a great day. I hope you enjoyed this short but important video on documentation.